Okay, hi everyone. So we're going to get started. We do have a jam-packed training, and probably one of the good things is to speak during this training, and I get to enjoy it. So we have Karen Timor, and she's the Director of the Downstate Outreach and Technical Assistance for the Uninsured Care Programs. That's a beautifully long title. In other words, she has great expertise on some of the programs we reviewed a few months ago, specifically Adap, and Apic and other related programs. And I know that when I did the overview about some of these programs, there were some questions about, like, how do we handle such a sensitive topic when we may believe that the client may be eligible for some of the programs. So I'm hoping Karen will be able to provide you guys some tips. This is obviously a more in-depth presentation, and she's going to be providing you with some resources. We will also have some materials that you can request in case you want to have handy in your office. And this is a great opportunity for you to expand your knowledge base, and you just never know who's going to walk into your office, and you want to be able to feel confident that you know sufficient information to be able to assist your client and or provide the appropriate referrals. I know that sometimes I get some clients and I do have these programs in mind, but I never quite feel comfortable describing them or talking more about it, and I usually provide a referral. So, and she's also going to be a great resource, so please pay attention to all the wonderful information she's going to share with you. After Karen's presentation, we're going to have Kyle come over, and he's going to do a quick overview of the tax forms. There is an entire training tomorrow, and be sure that you register. The state is giving out that training regarding the tax forms. So without any further ado, I'm going to turn it over to Karen, and of course you're going to get all the wonderful slides and additional resources that she gave us through email.
Great. Okay.
So thank you, Karen, for being here.
Oh, you're welcome. You're welcome. Okay, so I'm assuming that I moved the slide by hitting the tab. All right. So welcome, everybody. I'm so thrilled to be here. I'm a huge shout-out across the state. I'm so excited there's so many of you there. My name is Karen Timor, and I'm the Director of Downstate Outreach and Technical Assistance for the Adap programs, which is formerly known as the Uninsured Care Programs. This is Adap, Adap Plus, Adap HIV Home Care, and the Apic program, which stands for the Adap Plus Insurance Continuation Program. Apic pays for premiums, and we're going to talk about that in great detail. Just to, my slides are not advancing. Okay. All right. So just to set the frame for some of you who may not be, I mean, my world has got HIV all through it, but some of you may not have that experience. So just to kind of set the frame, the state says the number of people with HIV or AIDS in New York City is 104,690. These are folks who have HIV or AIDS who've been tested and who know that they're infected. All right? Now, I realized last night, I was thinking about this, that we're going to be doing statewide, so I looked at the figure for the state as a whole. So the state as a whole is 132,000 people who've been tested who have HIV or AIDS. The state estimates that there's probably an additional 20 to 25,000 additional people who have not been tested, who are infected, but who have no idea that they are. So the chances are good that in the course of your work, you are going to come across people who are HIV infected. Some of them will know that. Some of them won't. Some of them will tell you. Most of them will not. And so we've really put together this training with the idea that the client probably will not disclose to you. So how do you get across the information I'm going to give you without trying to force them to tell you, without soliciting that information? Mm-hmm. And there is an answer, and it is really easy. And hang on, we're going to get to that part, okay? So I just wanted to set the framework. You're in touch on a daily basis with people who know that they want health care and know that they want some way to pay for this. For people with HIV and AIDS, most of them, very shortly after they get into care, are going to be given prescriptions for HIV-related drugs. The cost of the antiviral drugs for most people is going to be $2,000 to $3,000 a month. Now, that is a cost that most working people are just not going to be able to float themselves, which is where our program comes in. So our mission is, first of all, to provide access to care for all New York residents with HIV. So anybody who does not qualify for Medicaid we're basically trying to do what we can to remove the barriers, the financial barriers between them and healthcare. We want to both empower folks with access to care and also to provide a stable funding stream for the safety net providers across New York State. Many of these are the neighborhood clinics, the small local hospitals, out there in the rural areas. You know that there are people who are uninsured who are coming for care. They're going to get the care, and then what's going to happen is if they don't have a way to pay for it, they're going to negotiate a sliding scale fee with the provider. Often what that means is that provider is going to take a hit on the cost and is going to get only part of the fee that they would have charged. With our programs in place, then they can get full reimbursement, and that can make a huge difference in helping some of those smaller institutions stay open and stay available, not only for people with HIV, but for people across the spectrum. So that's a big piece of our mission as well. There are 4 parts to our program. The part that we're going to be mostly speaking about today is the Apic program. This is the most recent part of our program. It started in 2000, and what Apic pays for is premiums. Apic does not pay deductibles or co-payments. Apic pays premiums for cost-effective coverage. Usually that's your silver, gold, or platinum plan, and we're going to talk about that in great detail. The oldest part of our program is Adap, and that's the AIDS Drug Assistance Program. It pays for prescription drug coverage. We are currently paying, it's here, it's got formulary of more than 500 drugs. It's coming close up on 700 drugs at this point. Adap Plus pays for limited outpatient care. So someone who does not have health insurance and who needs to have a way to pay for the doctor, the lab test, they can get Adap Plus. Adap Home Care is the smallest part of our programs at this point. Adap Home Care can pay for up to $30,000 of home health care in the client's lifetime. So again, that's not a lot of home health care, but that's better than zero, which is what most people have got saved up to pay for home health care. So eligibility. To be eligible for any part of our program, the person has to meet these criteria. First of all, they cannot have active New York State Medicaid. It's possible they've applied for New York State Medicaid. It hasn't come through yet for them. It's possible they had New York State Medicaid and they didn't recertify, or their recertification packet, they didn't get it, or there's been some kind of an interruption in their Medicaid. We can help with those folks. We can also help people have Medicaid with a spend down. But if someone has full active New York State Medicaid, they're not eligible for our programs. The person has to be living with HIV. They don't have to have AIDS. They don't have to have the symptoms, but they do have to have the virus. They have to live in New York State. They can be homeless. They also do not have to be here legally. They just have to be able to prove to us that they are living in New York State. So we can help people from people who are completely undocumented to people who are citizens and everything in between. We don't care what someone's immigration status is. And we don't share our information with anybody. So they don't have to worry about coming and getting in touch with us and having us help them with the cost is going to get them deported, because we don't share information with anybody. And a lot of different, INS, et cetera, have tried. We've fought relentlessly. The person must have liquid assets below $25,000. Okay? So liquid assets do not include your house or your car. Liquid assets are things like your checking account, your savings account, your stocks, your bonds. If somebody has retirement savings, so money in an IRA, 401k, 403b, New York City pension, New York State pension, or 414H contributions, those are also called deferred compensation. We don't need to see any of that as part of the application, and we will not consider it as part of the $25,000. So again, that list is IRA, Roth IRA, 401k, 403b, New York City pension, New York State pension, 414H contribution, which is also called deferred compensation. If someone has any money in any of those are what are called federally recognized retirement assets, and we will not include that as part of the liquid assets. The income level for our program, the person has to have an income below 435% of federal poverty. In 2014, that meant a single person had an income below $50,765. Okay? So you can see with that kind of an income level, we can really be a help for working New Yorkers across the state who don't qualify for Medicaid. Now that's for a single person. For each additional family member, we can add an additional $17,661 to the income limit. So if you've got a household where there's like 5 family members, they would need to have an income below about $125,000, $130,000 to qualify for our program. So you can see that we can really help people across a certain level of spectrum. In terms of income, if somebody is working and they have, they've got a paycheck coming in, we can further lower the income because what we're going to do is we're going to look at their gross income. We're going to subtract the money that is deducted from their gross for FICA and for Medicare. And then the amount that's left, that amount has to be below the $50,765. Okay? So for most of the cases you're seeing, probably you don't even have to worry about that because they're making $35,000, so don't even worry about that. But if you have someone who's right at the edge, know that we're going to take out the FICA and the Medicare before we consider whether they're eligible. If they're still a little bit over the $50,765, what we're going to do is if they have health insurance on the job and there's money that comes out of each paycheck to pay for their employee contribution, we're going to subtract that amount as well. And that may squeak them right under the $50,765. If we do that, however, we cannot reimburse them for that money that comes out of their check for the employee contribution. But so I hope I know that was pretty fast. Feel free to ask questions when we get to questions and answers. But I'm going to move right along because we've got a lot of stuff. Again, people who have active New York State Medicaid are not eligible for our program. Okay, Apic. These are the premiums that we can pay for. Now, most of these are not premiums that you're going to see. I'm just giving you this information because some of you may have people outside of the clients you're seeing as navigators who are HIV infected and who may need our help. So I want to just, I'm relentless on this. I have been photographed doing outreach about our programs online at the post office, and you better hope you're never sitting next to me on a flight leaving from any part of New York State. Because if you're in New York State getting on a plane, chances are good you're coming back. So you need to know about our program. So the Apic program, these are the contributions. So first of all, if somebody has insurance on the job, if they have an employee contribution coming out of every check, we can reimburse them for that money. So what we'll do is we'll mail the client a check every month for the money that's coming out of their paycheck to pay for their employee contribution. If someone has health insurance on the job, but then their hours or they lose that job, or they quit, or sometimes even they get fired. Under New York State law, if there's 2 employees where they work and they have the job for more than 3 months, they're entitled to COBRA continuation. And we can step in and pay their COBRA premium from the last day they worked. So COBRA is free. So keep that in mind for people who are working and who lose their job and who want to keep the coverage they had on the job. Coverage they buy directly from an insurance company or agent. So people who are admitted as you know, can get emergency Medicaid through the New York State of Health. But if they would like to have regular health insurance, they can go to the insurance company directly, and we can pay the premiums directly to the insurance company or agent. Okay, we got questions right here in the room. Yeah, talk to me.
I'm just wondering what the rationale is for paying for the premiums of someone who's getting health insurance in part through their employer.
Okay. So why would we do that? Why would we pay? Okay, because the reality is that for some people, if they don't have a way for someone else to pay that, they can't afford to take it. And so they'll turn that coverage down. Whereas if our goal, and the reason we have a rationale, the reason why we're paying for premiums at all, is again, if our mandate is to pay for drugs and medical care for people who are HIV infected, if they're on these antiviral drugs, it's going to be $2,000 to $3,000 a month. So we're going to set aside $36,000 just for drugs, and then we got doctor visits and lab tests on top of that. So for someone who just has an Adap Plus card, we're going to be committing upwards of $50,000 a year for their care. If that person has health insurance and we step in and pay the premium, it's cheaper for the state for them to have health insurance, and then we're going to send the bills for all that care to the insurance company. so it's cost effective. If someone is offered coverage on the job, but they're concerned about, I don't know if I can pay for this premium. First of all, coverage on the job, they're not even having to pay the full premium, a smaller portion. That's totally cost effective, because if they take that, we pay the premium for 10, 20, 30% of the cost of the premium. That person now has full health insurance, and we're going to flip those bills to the insurance company, and that's going to save the state money. That's going to free up those dollars.
That makes perfect sense. I wasn't thinking that there are employees who might opt not to take their employer-offered health insurance because they can't afford that.
Oh, yeah. No, we hear from those folks every day. So that's like another piece of the puzzle kind of thing. So, again, coverage, the person buys through the New York State of Health. We're going to talk about that in great detail in just a minute. People who have Medicare, and I know that, like I heard on the call, that some people have clients that have Medicare through the navigators. They're, people who are over 65 who have Medicare, they're not coming to the State of Health to get coverage. But outside of the work that you're doing with the State of Health, you may have clients who have Medicare or clients who are coming up on Medicare. So in order to pay for drugs through Medicare, there's something called a Part D plan. And that's a prescription drug plan that someone who wants drugs and who has Medicare, they're going to have to take that to pay for their medications. Some of those plans have premiums. We can step in and pay the premiums for their Part D plan. If they would prefer to get their care through a Medicare Advantage plan, which is a Medicare Managed Care HMO, and that combines their outpatient care and basically all their care into an HMO, there's often a premium for that. We can pay Medicare Advantage premiums as well. So know that those are all the different ways that we can use the Apic program to step in and pay premiums for clients. So again, the person has to meet our criteria to be eligible for Apic. So for any part of our program, they've got to meet the same criteria. The policy has to be cost effective. That means it has to cover the services covered by us and cost less than what we would have paid for those services. So what it means is it's got to have realistic drug coverage, and it's got to cover outpatient care. So the thing is, if the policy that they're thinking about, again, through the exchange, you're not going to have this issue, but some people who are working with, like New York City employees, they may have union coverage that has a limit on how much drugs they can pay for. So if the limit says we'll only pay for $5,000 for the drugs in the course of a year, that's not cost effective for us. We're going to give that client an Adap card and say, use our Adap card to get your drugs for free, but we can't pick up a policy that's not going to help us cost effective wise. And again, you don't have to evaluate this. If that's the situation, have the client call us. We have an 800 number, and we can take it from there. Okay? I'm just covering really quickly the highlights of this program. So what about coverage through the exchange? So if you want to use Apic to pay the premium costs for these clients, the plan they pick has to be cost effective. Generally speaking, that's going to be your silver, gold, or platinum plans. If the client chooses a bronze, they've chosen to pay for it themselves. We cannot help them. If they pick a bronze plan, if they pick a catastrophic plan, they've got to pick a silver, gold, or platinum plan because those are going to be cost effective. If they're eligible for the premium tax credit, so again, that's the subsidy to lower the amount of the premium, they have to choose to have it applied every month. They can't choose to pay the full premium and then get a big payout when they file their taxes because we just don't have the staff to be able to run that down. So if they want our help, they have to apply the subsidy every month to lower the cost of their premium. They should, if the client already has doctors that they want to use, they should absolutely make certain that those doctors accept the plan that they're considering. And again, people talked earlier on the call. I've heard a couple of the comments about people who are very upset about the no out-of-network coverage. That's really crucial. And one of the things, one of the things that Carolina said was give tips. So one of the things that we tell people all the time is call your doctor's office when you're considering which plans you are and ask them what are the plans they're in network for. Now you often get this garbage answer, which is we accept most insurances. This is not helpful information because, as you know better than I could ever tell you, Back in 2013, there were plans that had out-of-network coverage, and most of the plans through the exchange don't offer out-of-network coverage. So it's really crucial. What we usually say is, if that's the answer that you got, then you say to the receptionist, then tell me the plans you do not accept, if that's a shorter list, and tell me the plans you are in network for. I want to know what you're in network for, because if I pick a plan that is one of the few that your doctor doesn't accept, I can't come here, and I really want to see this doctor. So those are a couple tips on how to get that information. Again, these are calls that we're expecting that the client is going to make those calls, not you guys. Also make certain that the plan covers the client's medications. If the client is already on medications, if there are medications they know they're going to need, they should double check the formulary of the plan. Now, again, my world is HIV. I've been doing HIV work for decades, so I think everybody knows this. But just so you know, the antiviral drugs, when they first came in, most people are on what's called triple drug combinations. They're on 3 different drugs to fight HIV. Back in the day, those used to be 3 separate pills, and it was usually like, 24 or 30 pills you had to take a day for these medications. Now, most of the antivirals, especially the more recent ones, are 1 drug once a day. So you take a pill or 2 pills, and that's got all your antivirals in it. Some of those most recent medications, some of the plans, even some of the platinum plans, don't necessarily cover. So the client needs to double check if they know what medications they're on, check the formulary of the plans they're considering, and make certain those plans cover those medications. Okay? Moving right along. Additional ways that we can help. Okay? We can use Adap Plus to pay for some of the out-of-pocket expenses. Now, the premiums, that we use the Apic to pay for. Okay? We can use Adap Plus to pay for copayments, deductibles, just straight-out payment for some drugs. We can also use it to pay for Medicaid with a spend down. So one of the things you were talking about earlier was the clients that are who were on MAGI budgeting and who are now non-MAGI because they got Medicare, or they're over 65, or they just got SSD. So if somebody is now no longer MAGI eligible and they're going to non-MAGI budgeting, if they apply for Medicaid with a spend down and they get Medicaid with a spend down, then there's a certain amount of money that they're going to have to pay every month to get their Medicaid turned on. If that client is HIV, we will give them an Adap Plus card, and rather than spending their money, they can use their Adap Plus card at the pharmacy, pay for their medications. We will send them a receipt showing what we paid on their behalf, and they can use that receipt, send that in to DSS to meet their Medicaid spend down, so that they won't have to pay that cost themselves. And we can talk about that in great detail in the question and answer period if that's useful for you. Talking again about Medicare, just sneaking a little Medicare information in here. For people who have Medicare Part D, we can use Adap Plus to pay for the co-payments, the deductibles, the donut hole, the co-insurance, and we can use Apic to pay the premiums. So again, we're trying to figure out all the different ways that we can kind of plug some of the holes that you are getting in touch with that are in our healthcare system. There are over 164 hospitals and clinics statewide that accept our card, our Adap card, as payment in full for outpatient care. And there are 3,316 pharmacies statewide that accept our Adap card for medications. All the covered services and prescriptions are free for the participant. There's no copayments and no deductibles. In terms of Adap Plus, this is outpatient care. On their Adap card, they're going to have 35 clinic visits in a treatment year, which again is we'll get into treatment year if we need to. 24 mental health visits in a treatment year, 12 dental and oral surgery visits, 4 nutritional assessment and counseling sessions if they have HIV. If they have AIDS or symptoms related to HIV, we bump that up to 12 nutritional assessment and counseling sessions per year. We also pay for a broad range of lab tests, including tests for HIV, viral load, hepatitis C, HIV resistance testing. There's a ton of different lab tests that we can pay for, so that makes a big difference for folks as well. Okay, help for out-of-pocket costs for medications. So how does this exactly work to pay for the deductibles and the co-payments? So first of all, if someone has medications that they need to fill, what they're going to do is we're going to think about, first of all, is the medication covered by us? Does the client have a deductible, and has the deductible been met this year? Okay? So when they go to the pharmacy, they take both their insurance card and their Adap card. Okay? The pharmacist is going to bill the insurance company first. Anything that's left over, he's going to bill to us. Then the client walks out with their medications for free. Okay? If this is early in the year, so it's January. January's just around the corner, or January's here now. So if this is January, if the client has a deductible, the pharmacist, again, they walk in January 2nd or January 6th, since it's January 6th, give both their insurance card and the Adap card to the pharmacist. Excuse me. The pharmacist is going to bill first the insurance card. Now, they haven't met the deductible. Insurance company is going to come back with, they haven't met their deductible, we're not paying a thing. Everything that's left over, in this case, the full cost of medication, is then billed to us. We pay it. Client walks out of the pharmacy with their meds. Wait, it gets better. Because that pharmacy sent an electronic bill to the insurance company, and the insurance company knew that they didn't pay it, but that prescription was filled, they're going to count that payment, the payment that we're making. They're going to count that. They know that somebody paid it, and the drugs got filled. They're going to count that towards the deductible. So we're actually helping the client meet their deductible while they're still standing there in the window at the pharmacy. So that's why if the client has medications that are both on our program and medications that we don't pay for, because we only pay for certain kinds of medications, they should fill the medications that we pay for first. Because, remember, again, antiviral drugs, these are $2,000 to $3,000 a month. Then what's likely to happen is by filling those first 2 or 3 prescriptions of the year, that might meet their deductible right there. And while they're still standing at the pharmacy window, if they then fill the medications that we don't pay for because we met the deductible in the first 2 or 3 prescriptions, now they only have to pay co-payments. Yeah?
What kind of medications don't you pay for and why?
Okay. So the question was, what kind of medications don't we pay for? We actually pay for we pay for antiviral drugs, and we pay for medications for various opportunistic infections, the various infections related to HIV. We have a very broad definition of what we consider HIV related, because our mandate is to pay for HIV related drugs. So we pay for some antineoplastic drugs to treatment of cancer, because there are a lot of people with HIV who also have cancer. We also pay for psychotropic medications, because a lot of people with HIV have major mental illness, so we can pay for those. A certain number of people with HIV also have hepatitis A, B, or C, so we can pay for the medications for those. Now, there are very recent medications for hepatitis C. They've only come out in the last year that are extremely expensive. So we're talking, some of those medications are $8,000, $9,000, $10,000 a week. Those medications we can't pay for. So if the client has hepatitis C, they should call our hotline with the list of the medications, so we can tell them whether that's something that we pay for or not. We pay for heart disease medications, because a lot of clients with HIV have heart disease. We pay for diabetes medications, because a lot of people with HIV also have diabetes. Let's see, what am I leaving out? We pay for drugs for urinary incontinence, ophthalmological drugs, because there are a lot of eye-related complications of HIV, topical steroids, pain control, because there's a lot of issues with pain with late-stage HIV. We can pay for gastrointestinal medications, anti-diarrheal and malabsorption drugs, drugs to bring down someone's cholesterol and triglycerides. We can pay for Chantix if they want to stop smoking. We can pay for nicotine inhalers and nicotine nasal sprays to help them with stopping smoking. If they got heroin addiction, we can pay for buprenorphine if their doctor's willing to prescribe that. So there's a fairly wide range. There are some medications we don't pay. We will never be able to pay for Viagra, for example. Okay. There are other medications that someone may have for other things. I can't think of anything right off the hand, but I know that there are some. So again, they should sort out with their case manager, not with you, you're their navigator, but with their case manager, they should sort out which are their HIV-related things that we pay for and which don't they. And they can call our hotline and they can tell them over the phone. Okay? Okay. So what about doctor visits? So if they're going to an Adap Plus provider, they pay with their Adap Plus card, and that provider agreed not to bill the insurance for the primary care visits, the lab tests, the things that we pay for. So the client won't have a copayment and it won't count. There won't be an issue with the deductible. What we're going to do is we're going to take the bill, we're going to pay the providers, they're paid, they're done. We're going to flip that bill and send it to the insurance company. And again, when those bills come from us in asking for payment, they're going to count them towards their deductible. So going to the doctor, getting lab tests, that can also count to meet their deductible. So these are ways that we can help them with deductibles and copayments and make certain that they can get to a primary care doctor. We have a list of all our doctors statewide. I didn't give it to you simply because, again, have the client call us on our 800 number. We can refer them, and some clients, especially, they don't want to go to a provider in their county. So if they say, I want to go to somebody in this county, or I want to go to somebody in this zip code, that's fine. We'll give them whoever they want to go to. And we're also not managed care. So if they want to go to, they went to that doctor, they hated that doctor, they call us back, they say, I want to go to this doctor, fine, no problem. Well, I want to go to this doctor tomorrow, fine, great. Here's the phone number, here's where they are, give them a call, okay? Enrollment process, okay, for us to pay for their health insurance premium. So again, we're going to talk about this first because you guys are navigators. So the person sitting there with you, and let me back up just a minute and talk a little bit about, okay, wait a minute, they have to tell us they're HIV infected, so how are we going to do that? Because we're their navigator, we're not their case manager. So we sent you a sheet that says help with healthcare costs, and I think that got sent out to everybody on the call. Is that accurate?
Well, they're going to be getting it. I can bring it up.
Okay.
Give me one.
Hang on a second. The miracles of technology are going to bring it up so you can see this.
And if you know me, you know that I am technologically challenged, to say the least.
Help us, help us. There you go. You got it. You're doing great.
There you go. And again, you guys are getting all of this through your email after the training.
When we talked to navigators, they said, look, we were trained not to ask for medical information, and often the clients we're seeing, they're strangers to us. They don't know us, so they're not going to share this, and that's absolutely true, okay? So what we figured out was what are different ways. One of the things that navigators also told us is we talk to people, and we're sitting there helping them enroll, and they say to us, wait a minute, when they see the prices, I don't know, I can't afford this. This is way more than I was thinking it was going to be. So we said, okay, let's figure out a way that you can give them help with that. So we went out and started searching for plans that would help with premium payments, with drug costs, with the kinds of things you can pay for. And we found all these programs. All of these programs, we gave you a phone number and a website for every single one of them. And what you can do is when the client says, I don't know, I can't afford these costs. I mean, I'm looking at the silver plan, we're talking $200, whatever, hand them this sheet and say, here's a list that we got that has programs that can help you pay for premiums and drug costs. I don't know about your situation. Just go and scope this out. Go take this home, call these programs, check out their websites, see whether you and or a family member would qualify for this, and then come back and we can finalize your enrollment. Okay? Our program is on this sheet. It's the very last one on the list. But we found a bunch of other programs too. So we're giving you a ton of resources, not just for people who have HIV. So then the person, it's kind of like a Trojan horse. You've got the information in there, but you're not forcing them to tell you anything. I just want to, since we got the sheet up on the screen, I just want to point out the age 29 dependent coverage extension. Again, you guys know that as part of the Affordable Care Act, everybody can have their children on their coverage up to age 26. What you may not know is that New York State passed a law 5 or 6 years ago that if your employer will allow you to, you can have your kids on your coverage to age 29. So we have people that where their kids are bumping up against that, they're aging out of the age 26 piece. We wanted to just highlight that. And there's a great frequently asked questions that DFS has on their website to tell you more about that. So any of those resources are there. And you just hand them that sheet. They go off. They don't have to tell you anything. You don't have to ask them anything. And then when they come back, you can finalize.
So again, you guys are all going to be getting that sheet, and it's great. It's a one-pager. You can print a lot of copies and have them handy as you go through enrollment.
So let's say, okay, so the person comes back to you. You're finalizing their enrollment. Here's the deal. Again, once they enroll, as you know, about, what, a week to 10 days afterwards, they're going to get the bill from the insurance company saying, okay, I need my first premium, okay? So here's the deal. If they've disclosed to you, you can send them to a number of different places to get help with enrollment in our program. What they'll do is they'll take that bill, they'll fill out an Apic application, and if they don't already have an Adap card, they're going to fill out an Adap application as well. Send all of that to our office in Albany. What we will do is we will finalize once we've accepted them, which takes about 5 to 7 days, and then we will cut the check and we will send that with the invoice directly to the insurance company and pay their first premium. Okay? I hope that made some sense. So again, they're going to send the Apic application, which we have a 2-page application. They're going to send us the invoice from the insurance company. If they already have insurance cards, send the front and back of the insurance cards. If they don't yet have insurance cards, that's fine. Send us the 2-page Apic application, the invoice from the insurance company. If they're not already on the Adap program, they're going to need to send us an Adap application with proof of their income, their assets, their HIV, and that they live in New York State. Okay, that's the Apic enrollment. The Adap Plus enrollment, okay, again, it's a different 2-page application. There's a 2-page medical application to be filled out by their physician. And if they don't yet have a physician, you know, it's like, how can they pay for the physician to get the application to pay for the whatever? They can call our hotline. Any of the providers across the state will do an appointment for them for free to do the Adap application to verify that they're HIV infected, because that has to be done by a physician. But the physician's office will bill us for that visit. They won't have to pay a penny for it. And then we're also going to need supporting proof that they live in New York State, their income and their assets, and if they have health insurance, we need, again, copies front and back of their insurance card. So they're going to need proof that they live in New York State, proof of their income, proof of their liquid assets, and our hotline can fill them in completely on what we accept as proof. And I can answer questions on that if you'd like as well. So where can they get help filling out these applications? Our applications are online on our website, so if they just want to fill it out themselves, they can totally do that. They can just call our hotline if they have specific questions, and our hotline can answer it over the phone. Our hotline will accept calls across the entire state. But there are some agencies that we fund to specifically help people fill out these applications. All of these programs are free to the client, and they can come to the client or the client can come to them. In Manhattan, we split Manhattan into 2 sections, above Manhattan and below, above 110th Street and below 110th Street. So below 110th Street is AIDS Service Center, and then Manhattan above 110th Street is Harlem United. And for each of these agencies, I've given you the contact person, a phone number, the area that the languages that they speak, and their street address. Okay. Also, just because the client lives below 110th Street in Manhattan doesn't mean they have to go to AIDS Service Center, because, again, some clients are very concerned that no one knows. So if they say, I want to go to the Bronx, that's fine. They can go to any of these if they want to. Queens and Staten Island, AIDS Center of Queens County, ACQC, They're funded, and they send staff to Staten Island, and they have staff in Queens that can help. The Bronx is covered by Community Healthcare Network, and they will go anywhere in the Bronx and help anybody in the Bronx fill this out. Brooklyn, we split Brooklyn into 2 groups. Community Healthcare Network, they have a separate office in Brooklyn that will help people, and then Diaspora Community Services is also in Brooklyn. In the Mid-Hudson, Westchester, Putnam, Rockland, and Ulster counties, Hudson Valley Community Services, and again, they will come to the client, or the client can come to them, whichever would help. And in the Mid-Hudson, Sullivan, Orange, and Dutchess counties, Pathstone that's the agency that we're funding, that we've trained to do this. Yeah.
Do you think as an initial step, it's best to refer the client to your hotline, or should we refer people directly to these local?
Whichever. Yeah. Either one is fine. So whatever, if the agency has a really close connection already with somebody, then I know some of your navigators already have relationships with them, that's a fine referral. If they would prefer, or if they have folks who are outside of these service areas, just give them the hotline. And the hotline, our hotline is handpicked for nights. So those of you who are worried about, like, is it going to be like calling HRA? No, 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 no. And we don't, it's not like when you call and you get the phone message is not like dial 27 for rat bites, dial 38 for kayaks, dial 123 for, a trip to wherever. You may have a recording that says we're getting a lot of call volume. Please hang on. Your call is important to us. But then the next thing you're going to have is a live human person who will listen to you and help you. And our staff speak English and Spanish, and they're there from 8 in the morning to 5 o'clock at night, Monday through Friday. And if you've never called our hotline, call today, because it's a really special experience. And if you've been battered by calling HRA in the past, it's a completely different experience. So in the Capital District area, Columbia, Albany, Columbia County, Greene County, Montgomery County, Rensselaer, and Schenectady counties, that's Acton, AIDS Council of Northeastern New York. Now, I know that I'm feeling heat from all of Western New York, so I want you to hear that we are here for you. So call the hotline, because not only are these contractors trained, but any of the Adap Plus providers, we have trained their case managers and their social workers. So it's not just these agencies, but also all those medical hospitals and neighborhood clinics. They've gotten training from our staff on how to fill this out. So if you call and find out who are the Adap Plus providers in your area, their staff can also help with applications. But again, simple, easy to remember, just call the hotline. Have the client call the hotline, and they'll take it from there. Okay? So here's our hotline. If you want more information, we take calls from you, from clients, from basically anybody. When somebody calls, they pick up the phone, they say Department of Health. They don't say Adap, they don't say AIDS Drug Assistance Program, we say Department of Health. And if somebody calls and says, why does my husband have this card in his pocket? We say, we don't know, but we're the Department of Health, because nowhere on our card does it say HIV or AIDS. So again, our mandate is we not break anybody's confidentiality. So we have interpretive services available. Our staff speak English and Spanish, but we have access to the language line, and they can speak a broad range of languages for us. We also have a website, and on that website you can get our applications in English and Spanish, and then a broad range of information about our programs, including our brochures, which I also brought. We have brochures in hard copy, and those are printed up in 7 or 8 languages. The languages our brochures are printed in is English, Spanish, Korean, Chinese, French, Haitian Creole, Russian, and Italian. And then I also brought in Point Talk translators, which you can order on our order form. And these are basically, you can't see them, but they're basically a laminated sheet that has the basics of our program in the top 24 languages that we see people applying for. And what you do is you just hold it up so the client can see their language. We have 6 of these, so one has Spanish, Portuguese, French, and Haitian Creole on the card. The next one is African languages, so it's got Swahili, Arabic, Wolof, and Fulfulde. Then we have a pink card which has Russian, Greek, Hungarian, and Turkish. A yellow card which has Bengali, Hindi, Tagalog, and Thai. Tagalog is the language they speak in the Philippines. Blue card, which has simplified Chinese, traditional Chinese, and again, the difference is that someone who may not have had a lot of schooling in China before they immigrated, they're not going to maybe be able to speak or read traditional Chinese, but simplified Chinese uses a smaller number of ideograms. So we've got 2 different varieties of Chinese, Japanese and Korean, and then our last one has Italian, Polish, German, and Dutch. So those are free, and we sent you an order. We've got an order form, so you can order those for free. There's no charge for shipping. There's no charge for materials. You can order brochures. You can order point talk translators. We also have posters in English, Spanish, and French, and you can order those. And having the brochures and the posters up in your waiting area sends a message that AIDS is spoken here. The client may choose to just write the phone number down off the hotline, off the poster, and never say anything to you, and that's fine. The client may pick up a brochure and never say anything to you. That's another way for them to get word about it. So again, some clients are going to choose to disclose, some clients aren't. And by putting it out in lots of different ways, then someone can pick their own. Contact information. So again, here's the hotline. The fax number, you can send applications into our fax number. We're assuming you're not going to be doing applications, but if the client wants to fax it into us, they can. Both of those are secure faxes. They don't have to worry about someone getting information about them that shouldn't have it. We have a totally different office in Albany. It's separate. It's a separate building from the rest of the Department of Health. And then my information and my colleague in the New York City office is named Francisco Diaz. That's our phone number and that's our email, and feel free to contact us. Again, we're field staff, so our job is to be out doing presentations about this program. So sometimes you may have to wait for us to get back to you. Call the hotline, because the hotline is there and answering the phones Monday through Friday, 8 to 5. But we want to just give you lots of resources any which way we can. And I think those are my slides. Very quickly, at a fast run. Questions?
Great. Awesome. Thank you.
Oh, we're very excited.
Wow.
So that was a great presentation, and the resources are phenomenal. I will be sending you guys the order form, and obviously you cannot see the brochures, but they're like really nice, and the different language cards are really useful because you can probably help a lot more clients, even if you don't know their specific language, at least to get them to that referral and give them, again, the resources that they may need to be able to follow up. So don't we wish it was as simple as, like, you know, there's always Plan B. They can get their prescription covered. So this is a great program for obviously a very special population that they, again, I think if there's a theme in this first monthly meeting is the positive in circumstances that may be a little bit gloomy at times, but there's definitely resources out there and a positive outlook in those circumstances. So great resources. We probably have a few questions, and Leon is going to read them out loud, and then we'll get hopefully answers. If not, we'll follow up with you.
All right. So first question. I have a client who is HIV positive. She is undocumented from a country in Africa. The marketplace will not allow her to enroll without some form of documentation, which she does not have since she has moved so many times. We have her enrolled in the HUCP program plans you described. Do you know of any private insurer who will insure her? She also has a son under the age of 19 who cannot enroll in the marketplace because she needs to be the primary client on the application.
So, okay, first of all, just to go to the son. Again, I don't know that much about Child Health Plus, but I thought for all children in Child Health Plus, even if the parent wasn't insured. Is that not accurate?
That is correct. Actually, the second part is a navigator question, which I think could address. She just stepped out. So
okay.
I'm vaguely familiar, but she should confirm this idea that the parent has to be the head of household. But
correct.
I don't know if that's true. She should confirm.
Correct. Okay. So yes, so the parent does have to be. It's like a two-part question. So if you could just answer the first part,
right,
and then we'll deal with the second part.
So we do know that there are insurance companies that will sell a policy to people who are undocumented. Okay? We don't have, just to be honest, we don't have the staff to do the research to know which are those across the state.
Mm-hmm.
So you're going to have to refer her to a case manager who can sit and call the insurance companies and find out which ones in her area would sell her a policy.
Mm-hmm.
But if you can find one that will sell her a policy, we'll pay for it. And just to put the premium, just to put the information out, we've been paying premiums for people, undocumented or documented, with HIV since 2000 across the state. So there are companies out there that will sell policies. Again, it changes sometimes from year to year. You're finding even some changes in your plans between 2014 and 2015. So we just don't have the staff to keep up to speed on that. But again, what basically would do is the case manager would call the different insurance companies, find out which one in her area would sell her a policy, download that application, fill it out, send the application to us with an Apic application. The client's already on our program. Our formal name is the HIV Uninsured Care Program, so the HUCP, that's what that is. So this client already has an Adap card. All you need to do now is the Apic application. It's that 2-page application. Send us the application from the insurance company with it. We'll process the 2 of them, cut the check for the first month's premium, and send that off with the application directly to the insurance company. So that's how we can enroll the undocumented folks.
All right, great. So, yes, go ahead.
Just a follow-up. And here, if they want to do it to the marketplace, they have to make sure one of the marketplace plans will enroll someone who's undocumented H, or not necessarily?
Will they?
Well, usually you need some, through the marketplace you can enroll into emergency Medicaid if you're undocumented. If it's going to be something for someone that's undocumented, you usually have to purchase that directly from the health insurance company.
So for the mom, this won't be through the marketplace.
Right. All right, so what I'm going to say, Carolina just stepped back into the room, but if Janine, you could reach out to Carolina directly and just work out so we can get some more questions in. The second part of the question is the navigator question, and we can work directly with you to get that resolved. All right, let me just move to the next question because we do have another presenter that just stepped into the room. Okay, I just want to say the last open enrollment, I had a self-employed man who had Adap because he could not get health insurance before the ACA. He cried when he completed the enrollment in a platinum plan because Apic is helping him.
Oh, that's wonderful. Thank you so much for sharing that. Yeah, that's our job. It makes my day completely to hear those stories. We're here for you. We're trying to help people across the state, and the self-employed people, I'm haunted by them because many of them are out there working and doing what they can. So yeah, it's a privilege to be able to help them. Thank you.
All right.
How does a client make a decision of whether they go with a silver plan, a gold plan, or a platinum plan if they are eligible for this program, for the premium assistance in particular?
Okay. Well, what I would say is if they know that we're going to be able to pay for the premium, then they should think about the care that they need and which of those plans is going to cost them the least out of pocket. So they're going to still, for the things that we can't pay for. So we can't pay for hospitalizations. We can't pay for emergency visits. We cannot pay for X-rays, MRIs, CAT scans. If they need any of those things, they're going to have to pay the copayment. Okay? So what I would say is look at the plan. Look at what the out-of-pocket cost is going to be for some of the things that you know we can't pay for. So if you ever should need an ambulance, if you ever should need hospitalization, if you ever should need an emergency room, what's the copayment going to be for a silver plan, a gold plan, a platinum plan? We're fine with paying for any of those. So, you know, the premium, but the out-of-pocket is what the client's going to have to pick. So then I would say pick on the basis of what's going to be the least copayment if I should need an emergency room, an X-ray, et cetera.
Okay, so as a follow-up and not to put you on the spot, based on your obviously first-year experience from seeing clients who are now eligible through the marketplace, is there a metal level that is more popular? Obviously, I'm thinking platinum has the less out-of-pocket, but from your experience, is there like a level that you've seen usually clients who are eligible for this program select?
Well, what you want to be thinking about again is what does your doctor take, and what covers your medications, and then what's going to bring you the least out of pocket for those co-payments and things.
Great. So the general tip of like making sure that the client's needs are going to be met from basics are prescriptions covered, doctors, and then obviously the out-of-pocket still then, and probably more critical for this population, specifically when it comes to prescriptions. So that's great.
All right. Okay, so some of the questions get moved around here, but just someone says, I guess in response to that, someone said, I usually enroll individuals into platinum plans, just to address that plan. It sounds like that's a sensible option because it's no deductible and they do cover, it's a low out-of-pocket services. Okay. Our next person says, if a consumer selects a silver, gold, or platinum plan that does not cover dental, will Apic also pay for a dental plan, like an independent dental plan?
Apic, we can only pay for the premium that's covering the drugs and the doctor visits.
Okay.
So we can't pay for a separate dental plan. That client would be eligible to have an Adap Plus card, which could pay for 12 dental and oral surgery visits. Again, if they need extensive dental care, they're probably going to have to start budgeting up for that. But by using some of our other things, that can cover some of their out-of-medical costs, which may free up dollars that they could then spend for extensive dental work if that's what they need.
If the dental plan was embedded in the medical, it would be covered, right?
Yep.
Like the premium would be covered. Okay.
All right, great. Okay, someone here makes a comment. I work at a clinic that serves mostly the HIV population in the area and find that Adap/Apic programs make enrollment very easy.
Yes. Thank you for the feedback. That's our job. We're striving for that. It's good to hear that the work is working.
Okay. Is this a New York City or New York State program? Does it provide coverage more specifically to consumers in Long Island?
Oh, absolutely. Are you kidding? And Long Island is my territory, so whoever's asking this question, give me a call. We can come out. We can do training for your staff, training for anybody in the downstate region, which is Nassau, Suffolk, all 5 boroughs, Westchester, Putnam, and Rockland counties. So my particular team, we can go out in that area. We're statewide, really statewide. Not only Long Island, all the way to Montauk and right to the water, but all the way out. And I hear you, Niagara and Buffalo, all the way out that way. And up to the North Country, Plattsburgh, I'm looking at you. Rochester, we want to reach all those folks in the rural areas in between. So yeah, we're statewide.
Okay, it says, this is feedback. My client did call the doctor while I was there, and they told him what works best. This is Cheryl. Again, awesome information. Thank you.
Oh, you're very welcome.
Okay, one more here. What about vision coverage, as individuals with HIV often have eye issues?
Okay. So again, we can pay for only the premium that covers the drugs and doctor visits. If the vision is part of that, we can pay for that. If they need to go to the doctor for a vision care, so not like glasses, we can't pay for glasses, we can't pay for contact lenses, but if they need to go to an ophthalmologist for their HIV-related eye care, if that ophthalmologist accepts Adap Plus, they can use their Adap Plus card to go for free.
Okay.
And if they want help tracking down who in the area does that, call the hotline.
And I guess I could mention that some non-standard marketplace plans offer vision and dental as part of the package. So if the client was to select one of those plans, Apic would pay that premium, and those services will be covered. But it has to be part of the health insurance. It can't be a separate dental or vision plan. Okay, let me just see here. I think that's it for questions. Any other additional questions? Let me just see here if anyone wants to ask any verbal questions. Let me just. Give me a moment here. I'm just looking to see if you have any verbal questions. Okay. Tina, did you have a question? I see you have your hand raised.
I was just going to say that, can you hear me?
Yes.
I was just going to say that I get a lot of referrals from ECMC, and it's worked wonderful. They've been very wonderful, and there's no problem. They say to pick the best plan, and it's really a wonderful program.
Fantastic. We're thrilled to hear it. Thank you for the feedback.
Sure.
All right, so a final call for any questions, any verbal questions. You can raise your virtual hand. I'll mute you so you can address the entire group. All right, any final questions? Okay, well, you have, Corinne, okay, hold on here. Okay, this person, Arlene Cruz, you do not have your audio pin entered, so I cannot unmute you. You cannot address the entire group. It says consumers apply for Apic, Adap, and A+.
Adap+, yeah. Consumers can, if the consumer wants to apply themselves, if they don't want to involve any other third person, they absolutely can. Our applications are online. They're only going to get Apic if they have to have help for premiums. So, but yeah, the consumer can apply directly if they would prefer. There's one thing I just forgot to say right before.
Oh, Arlene? Yes, we got you, Arlene.
Okay, sorry. No, I just wanted a little bit of clarification. Can a consumer apply for all 3 programs, or can you only apply for one program at a time?
Oh, no, you can apply for all of them, and you can apply for all of them at one time if you want. We have totally different eligibility teams to process the applications. So it's not like you have to wait, apply for Adap and then wait 3 weeks and then apply for Apic. Send it all in one go. We'll separate it out. We got a team going, and right now it's open enrollment. So we're working 60 to the dozen trying to get applications spun out as fast as we possibly can. So absolutely.
Okay, thank you.
Welcome. In fact, we're thrilled. Every person that applies for Apic is helping out our programs, because our programs get a set amount of money from Congress to run the entire program statewide. And every client that you get health insurance for, what that means is that saves the state money. So we have that money sitting ready for the next person who comes in who doesn't have anything. We can immediately give them Adap Plus while we're waiting for them to get health insurance, and we've got the money to then spend on their drugs and their doctor visits. So literally, it's beyond life-saving. What you were talking about earlier, Leon, around, you're changing people's lives. Every single person that you get enrolled in health insurance, you're making it possible for us to help more people without going back to the taxpayers and asking for more money. So we're stretching those dollars and making the safety net bigger and better. So absolutely, anybody that wants it, we're thrilled to help them with that. One little piece I forgot, I just want to mention in passing. If you have someone who we found last year that some of the insurance companies had the first premium sent to one address, and then the second premium and every other premium after that sent to a different address. So we had some clients that they knew that we were paying for their premiums, so they just stopped opening the invoices, because they're going to get invoiced from the insurance company every single month, right? And they knew, well, Apic's paying for it, so I don't even have to open it up. So they didn't. And because we were only told send the premium to this address, so we just continued to send it to that address, because the insurance company said, no, we want the second premium and the third premium and the fourth premium to go to address B. We never heard about address B, and the insurance company didn't get the money that they wanted where they wanted it, so they ended the coverage. So one of the things to tell clients is, open every invoice, double check. Is it the same address? Did they move it? Do they want it to go a different place? If it is a different place, call us on the hotline and tell us, so that we can then shift and send the payment where the insurance company wants it. So again, just one of those little dips and quips and things that we all figure out from doing. So I think that was everything I could think of.
Okay.
It's
so
wonderful.
I'll make a final call if for questions. Okay. All right. We got to move on. You have our contact information. Karen gives all her contact information in the presentation, and we're going to send it out by email. So thank you very much.
And we want to thank Karen. I mean, this is kind of like the trainings I'm sure you have all been asking for, where there's a level of expertise, someone who's knowledgeable about the marketplace and the issues that you are facing with your clients. So, Karen, thank you so much. That was a wonderful presentation and great resource.
Wonderful. Thank you so much.
So give us 1 minute, 30 seconds maybe, and Kyle is here. So for those of you who missed Kyle, he is going to be doing the next part. We're going to try to be within our time limit. We're not going to have a lot of marketplace updates. If we don't get to them, you will get the PowerPoint presentation, and you can just review them. So we're going to try to be mindful of your time, and Kyle is going to go over the tax forms, not in depth. As a reminder, everyone through the weekly email got the login information for tomorrow's training. That training the state is giving, and it has to do with the tax forms consumers are going to be getting, letting them know of what health insurance coverage they had for 2014, and they're going to need that form to file their taxes. Without further ado, I am going to turn it over to Kyle.
Hi everyone, it's Kyle. I'm going to get moving so that I can make sure to respect your time. As Carolina said, there is going to be a whole webinar on the 1095A, what navigators need to know. It's essentially like an inning 11 or 12, whichever inning number the marketplace is on now. The person who will be doing the training is the person who's running the 1095A project over at the marketplace. So they'll have a depth of knowledge as well. But we wanted to just give you a primer so that you're not seeing this material for the first time tomorrow. And additionally, we'll just kind of walk through what, so maybe we can handle some of the questions that otherwise might not get handled tomorrow. So feel free to try to stop me as I'm going, raise hands, put in questions, and I'll try to monitor that as well. But let's get moving. This is a slimmed down presentation that we're getting approved by the state. But the first thing that we're trying to make apparent to navigators and enrollees is the distinction between PTCs and APTCs. Hold on just a second. Sorry about that. As I was saying, we're trying to explain the distinction between PTCs and APTCs. We've all been talking about APTCs for over a year now, so we're all very comfortable with advanced premium tax credits. But the IRS never refers to an APTC in its literature. It only refers to the PTC, the premium tax credit. The APTC is just these advanced payments of a tax credit that can otherwise be applied for when the taxpayer files their taxes at the end of the year. So what I've tried to do with this Venn diagram is to kind of explain the distinction between PTC and the APTC. So the premium tax credit is calculated at tax filing time. There's no estimated income, or the taxpayer may have estimated their income, but it was higher than, their estimation was higher than their actual income, so now they become eligible, etc. So the PTC is calculated at tax time. There's no reconciliation. The PTC does not need to be applied for. You do not need to file for the premium tax credit just because you receive a 1095A. If you know you're not eligible for it, there's no sense in filing the forms. That's the distinction between the APTC. If you took advanced premium tax credits, you must file these forms that we're going to go through, because you have to reconcile your estimated versus actual income and either get more credits at the end of the year or return some of the credits. All plans that are purchased through the New York State of Health are eligible for both PTC and APTC. Those are the only plans that are eligible for these. You must purchase your health insurance on the marketplace to be eligible for either program. And really it's one program, it's just an advance of the other one. And something that we're just emphasizing is that the tax credits, regardless of whether or not they're advanced or just filed for at the end of the year, they're not available on catastrophic plans. So I hope that's clear. I'm going to move on. We can handle questions at the end or as they come up. It looks like I'm already getting some questions. So here's the timeline. The timeline for the APTCs is on the top. The PTCs are on the bottom. So on the top, the taxpayer estimates their income and begins receiving APTCs at the date of enrollment until the end of the year. Those APTCs will be based on their income, and then the renewal process will give them APTCs for the following year. So the estimated income only applies to 2014. And then during the tax filing time from January 1 to April 15th, the taxpayer will reconcile their estimated income versus their actual income, and then either return some of the tax. With the premium tax credits, the timeline on the bottom, the taxpayer either says, I don't want to be screened for financial assistance when they fill out the application, so they never estimate their income, or they estimate their income and they're not eligible for the APTCs, or they are eligible for the APTCs and choose to take 0% of them. Those are pretty much your three primary situations. And the taxpayer just doesn't receive any advanced premium tax credits and pays the full monthly premium. Then at the end of the year, if the taxpayer so chooses, the taxpayer can fill out the forms we're going to go through and file for the premium tax credit at the end of the year. So they've paid their full monthly premium, and it's just at the end of the year that they'll check to see if they're eligible for the PTC. So this is the reconciliation process. I was told yesterday that truing up might be a Midwestern term, so I apologize if that's not clear to everybody. Truing up just means to reconcile or to match two things together. It's also a carpentry term, so I could be just showing my roots there. So the reconciliation process starts at the enrollment. The taxpayer must request financial assistance. They must estimate their 2014 income and then be screened for eligibility for the APTC. Now, just because they do that doesn't mean they took the APTCs, but that's the first step in the process. So they enroll and they request financial assistance and are screened to be eligible for APTCs. Then they actually work in 2014. That's their 2014 income. And depending on the amount of APTCs the taxpayer took, their actual income will do one of the following three things. It will either equal the estimated income, in which case there's no actual reconciliation. They've taken the appropriate amount of APTCs, and they're just good with the IRS. The second thing is the taxpayer's estimated income, or I'm sorry, actual income will exceed their estimated income, in which case they've taken too many APTCs, and they're going to have to give some of the money back. And finally, the actual income might be less than their estimated income. In that situation, they're going to receive more premium tax credits at the end of the year. Notice I said premium tax credits and not APTCs because they can't receive them in advance. They can only receive them at tax time, which is step 3, tax time. Sometime, and the reason why we have February here, technically a taxpayer can file their taxes any time after the tax year, so technically they can file in January, but the forms are going to go through the 1095A or their W-2s or 1099s before February 1st. All employers, payors, and the marketplace are required to give the W-2s, 1099s, et cetera, to the taxpayer by the end of January. So really, in actuality, we're looking at February to sometime in February to April 15th, and the taxpayer could reasonably file their taxes. And so on step 3 at tax time, the taxpayer actually reconciles their annual income, their actual income, versus the APTCs they received, or they file for the PTCs for the first time. And remember, there's no reconciliation for PTC. Because they didn't receive any advance payments, the taxpayer isn't reconciling anything. They're not, again, truing up those numbers. They're just filing for the first time. They either said they didn't want financial assistance or they chose not to take the APTCs, and they're getting the tax credit for the first time, which means they're just going to get a huge refund. So I've been saying over and over that when a taxpayer actually reconciles, they may have to pay back some of the tax credits. This is the repayment cap. As long as a taxpayer remains eligible for tax credits, they don't have to pay back all the tax credits if they took too many. If they're no longer eligible for the tax credits, then they'll have to pay back everything. And when I'm talking about eligibility, I'm talking about eligibility determined by their percentage level of FPL. So if you're less than 200% of FPL and you're filing singly, the most you'll ever have to pay back is $300. You may have taken $1,000 too much in APTCs, but you'll never have to pay back more than that $300 amount. So it at least gives consumers a number that they know they won't have to pay back more than, unless they, estimated they were going to make 250% FPL, ended up making 450% FPL. They're going to have to give back all their APTCs, but if they qualify for CSRs, they're not going to have to return any break they got through the cost-sharing reductions. So I hope that's clear. The repayment cap applies to the premium tax credits, not to CSRs, and only applies if the individual took APTCs. It doesn't apply to PTCs because you can't be paying anything back because you didn't receive advance payments. And finally, this is just in here. It's a reminder because this is tax time. This is the first time that individuals will be encountering the shared responsibility payment. So I just want everyone to remember that individuals for the first time who chose to remain uncovered are going to have to pay some penalty for not being covered. Of course, there are exceptions. There's the gap for less than 3 months. For this first year, the option for anyone who enrolled during the first open enrollment, even if they exceeded those 3 months. So let's say they enrolled, on April 14th. Obviously, they were uncovered from January 1 to April 14th, which is 3.5 months. But they're fine because they got in during the first open enrollment. And, of course, the one-day rule we just want to mention again, as long as an individual has coverage 1 day in a month, they're covered for the whole month. So, just because you got coverage through your job on March 30th, it's still a 3-month gap because you only were, or it's a less than 3-month gap because you only were uncovered for January and February because March is covered by your being covered on March 30th. All right, so I've been talking about the IRS forms. Let's actually look at them. We have all been looking at the 1040 when we've been trying to estimate income. You'll see at the very top of the form, this is for 2014. In 2014, we have a new line. This is for the individual shared responsibility payment. Line 61 is where that tax or penalty or payment or however you want to refer is going to be put on the. If an individual had minimum essential coverage all year, they get to just check that box, that full year coverage box, and move on. They're done. They don't have to put a number in there. They don't have to put a 0 in there. They just move on. If the taxpayer was not covered, all we see, and they need to file for an exemption, like the 3-month gap, or open enrollment, or because they're Amish, or any of the number of exemptions we've talked about since last open, then they need to fill out Form 8965, which will either allow them to claim their exemption or will help them calculate their penalty. If they do owe the penalty, that number will go in box 61, and that will explain exactly, or Form 8965 will walk a consumer through calculating that, especially if they had coverage for some of the months, but not all the months. Maybe they lost coverage in June for failure to pay or something like that. In those situations, the taxpayer will have to calculate the total penalty, divide by 12, multiplied by the number of months, and this form walks them through that. Of course, you're not responsible for filling out Form 8965. I just want you to know what you'll be seeing new when people come to you to either enroll for the first time or renew with their 2014 1040s. You'll know what this line means. So the next form we're going to look at is the 1095A, but I just wanted to explain the process timeline we've gotten from the New York State of Health. Between January 16th and January 30th of this year, New York State of Health is both snail mailing, that's via the post office, and placing the 1095A in your consumers' inboxes. The 1095A will become oh, I pushed a button. Sorry about that. The 1095A will become available the same day that the form is snail mailed to the consumer. So on the first day, they're mailing 32,000, and over the next, the next 15 days, they're mailing 32,000 every day. The total amount that are being mailed out to consumers is 323,000 1095As. Those are the total number of households that applied for private insurance through the New York State of Health, and regardless of whether or not they took APTCs, they're getting the 1095A so that they can determine whether or not they want to file for the PTCs. Again, February 15th, April 15th, the taxpayer can begin filing their taxes as soon as they get all their forms, but really we're expecting sometime mid-February to April 15th, most people will finally get all their forms and be ready to file. The following slides are the 1095A and the form that they fill out if they want PTCs. So this is the 1095A. This is the statement they're going to receive from New York State of Health. Anyone who enrolled in private insurance in a bronze, silver, gold, or platinum plan will be receiving this form. If they didn't take any APTCs, all of Part 3 is going to be empty, except for the total monthly premium amount that that consumer paid. So Box A will be completed, but they didn't take APTC, so the rest will not be completed. A couple of boxes I just want to point out, so if the consumer comes with it to you, in Part 1, the taxpayer's information will be there. Box 2 will have their account number, but it's going to be, and we're not sure what this looks like because we haven't seen it yet, it's going to be a part of a code. Their number will be in there somewhere, and that's what we've been told. But there's going to be other information in that box that details something to the marketplace, but won't mean anything to us as navigators or consumers. But their account number will be in there somewhere. A consumer should check Part 2 to make sure that all the covered people in their household are actually listed in Part 2. And then Part 3 is going to have all the information about their total monthly premium, which is Box A, the APTCs, if they chose to take them, the second lowest cost silver plan will be in Box B. This is only if they took APTCs because it's calculated by the county of residence of the individual taxpayer. If they chose not to take APTCs, even though the marketplace knows their county of residence, they're not going to fill that out for them. The taxpayer is going to have to select it from a chart, and we're going to get into that in just a minute. And then finally, column C, for those who took the monthly APTC, it will list out how much was paid each month. For an individual who is enrolled for January 1 coverage, unless they made a life change event, the same number will appear in all of the boxes. In box 21 through 32 under box C. Same number is going to be there because that's the amount of APTCs they received each month. Oh, because I turned it into a PDF. Sorry about that. My little red arrow is supposed to appear afterwards. I was sad my animation didn't work. Anyway, if the taxpayer comes to you and says, hey, I tried to file my taxes, but the accountant or the tax preparer or the H&R Block representative or whoever told me I need this form from the marketplace, you're my navigator, where is it? You can help the consumer after January 31st. It will be in all the inboxes. All you have to do is log into the consumer's account, click the inbox, which my big red arrow is supposed to appear at that point, and the 1095A is going to be right there. So you can help the consumer access it, print it out for the consumer, and give it to them if you need to. The consumer needs to be the one accessing this form, though. You can just tell them how to do it. And I mentioned the second lowest cost silver plan previously. This is what the chart looks like. Obviously, this isn't the full chart. It's just the first page of the chart. You'll notice it's in alphabetical order and ends on New York County. There's other counties in the state that go beyond N. So a taxpayer is going to have to select the appropriate second lowest cost silver plan to calculate their premium tax credit if they didn't take APTCs. At this point, I just want to mention one little hiccup, that a taxpayer might be below 400% FPL and not receive any premium tax credits. And they'll ask you why. The answer is typically because the second lowest cost silver plan, that terrible acronym, SLCSP, and I keep putting it in there because I want you to get used to seeing it, because that's how the IRS is going to refer to it, is the SLCSP. And it's just a terrible, terrible acronym. But just get used to it because you'll be seeing it a lot. The second lowest cost silver plan in that county of residence was considered affordable for your consumer. So let's say you made 375% FPL. You're otherwise eligible for premium tax credits. However, the SLCSP in the county of my residence, like Albany County, we've done the math, there's a plan in Albany County from Health Republic that is affordable. I don't need any contribution from the federal government to be able to afford that plan at the expected contribution percentage. The expected contribution percentage is fixed from 300 to 400% FPL at 9.5%. So if I have to spend less than 9.5% of my MAGI to purchase a plan, I don't get any help from the federal government. And there are plans across the state that are actually affordable, below 400% FPL. So I just want you to know that some people might not be eligible for premium tax credits despite being below 400%. So I just wanted to touch on that while we had the chart up so that you would just remember that one little wrinkle. This is the last form we're going to go through today. It's Form 8962. And this is the reconciliation form. You'll see it's significantly more complicated than the 1095A. What this form is designed to do is both determine a taxpayer's eligibility for premium tax credits if they never filed for it, and to reconcile APTCs if they are eligible for the tax credit and they took the advance payment. So this form will walk a consumer through. You'll notice line 28 is that repayment cap we went through. So even if they show that they owe back, let's say $1,200, when they get to line 28, it'll be capped at $300 if they made less than 200% FPL. So, you know, if a consumer comes in and is showing you a box 26 where they owe $2,000, walk them down on line 28 where the repayment cap applies, as long as they still were eligible for the premium tax credit. They didn't actually make more than 400% FPL. So that's the form the consumer is responsible for filling out once they get this form from the New York State of Health. This form, you take and you use that information to fill out this form. So I have about 4 minutes left. I just want to talk about what your responsibilities are. As navigators, we need to know how a consumer can find their 1095A. Just in their inbox, we need to be able to help them get to that inbox and access it. You need to know what a 1095A is, who will receive it, and why it is important. You need to know the difference between PTC and APTC. What is a premium tax credit, and how does it differ from an advanced premium tax credit? What are the rights and responsibilities of getting an APTC versus a PTC? Do you need to file Form 8962 if you got APTC? Yes. Do you need to file it if you want PTCs? Yes. If you have no interest in getting any financial assistance regardless of what you made, you never have to fill out Form 8962 if you did not receive APTCs. We need to know how to direct consumers to additional information. We're going to go over that in the next slide. And you need to know how to make a life status change in 2015. This is just a part of your navigator training, but it applies to tax credits because it might modify their APTCs mid-year to make sure that they don't have to pay back money at the end of the year. Things you don't need to do. You do not need to know how to fill out Form 8962, that complicated form we just looked at, this one. You don't need to know how to fill this out. You need to know what it looks like, and you need to know what its role is, but you don't have to sit down with the consumer and help them fill it out. You are not a tax preparer. You do not need to check a consumer's taxes to make sure they filled them out correctly. Again, you're not a tax preparer. You do not need to know other tax information. You're not a tax attorney, a tax preparer, CPA, an accountant, anything. You just need to know those five bullet points that we talked about above. Finally, Navigators and CACs may not give tax advice. We are not advising people on how to file their taxes. We're not telling them what is or is not income. That's for their tax preparer to determine. So we do not give tax advice. We do need to know, however, what the 1095A is, what the 8962 looks like, and the distinctions between premium tax credits and APTCs. So I said you need to know where they can get help. This is where a consumer can get help. CHA is establishing, and by CHA, in case anyone doesn't know, Consumer Health Advocates, it's CSS's helpline right here in this building. CHA is establishing a new helpline that will assist consumers with basic information about PTCs, the new IRS forms. It will explain to consumers how to get their 1095As. This is more for the tax preparer community. You're supposed to know that as well. We're going to help consumers select the correct second lowest cost silver plan. You don't need to know how to do that. We will know how to do that, so just direct them to our 888-614-5400 number. The New York State of Health is also establishing a dedicated line, and that's that number that we have there. That line is not active now, so if you direct a consumer to that number right now, it's dead. So don't give out that number until after January 31st. But we want you to know that there will be a dedicated line to help a consumer. This number should be given to a consumer when they disagree with their 1095A, or they never received it and cannot access it on their own through the Internet. We may not access a form for a consumer and then mail it to them if they don't come to our office. They can access it in our office. They can print it out. But this is a tax form. It has sensitive information on it. We're not to be sending this off to every consumer who calls you. If they can't access it through the Internet on their own, then they need to call this number and have a new one sent to their mailing address. Again, if they disagree with the 1095A, they can access it, or they need to contact New York State of Health to get a corrected version. And just so everyone can imagine this, this is the 1095A. You see the box in the top right corner next to 2014. If there's a check mark in there, that means this is a new version of the 1095A issued to that taxpayer, because the New York State of Health has accepted something that the taxpayer has told them, and it's sending a corrected version so that they can file their taxes correctly. Finally, if they want tax advice, tell them to see their tax preparer, their CPA, their tax attorney. If they don't have any of those, they need to contact the IRS. The IRS is not creating a dedicated helpline for this. They need to go to irs.gov and find that information there, because we are not giving out tax advice. I'm just going to keep harping on that. So here are some resources. New York State of Health has created a dedicated page to the tax credits. It has the 1095A, or will have the 1095A cover letters. When all of these 1095As are mailed out, 32,000 a day, beginning January 16th, there'll be a nice little cover letter with our number on it and the New York State of Health number on it, and it will explain why the consumer is receiving this form. So there will be an introductory cover letter. The SLCSP table will be on there. You just saw that. There will be an FAQ. We have to finalize it with New York State of Health by Thursday of this week. And there will be additional consumer information. There will also be the webinar posted there that you will see tomorrow. There's IRS information at this link here. And, of course, the taxpayer community across the state is being well trained for this, including the no-cost tax preparers through the VITA and TCE programs. They're all being well trained on this as well. So let's see if we have any questions. I probably have a minute to take questions. All right, first question. If someone isn't covered from September to December 2014, do they pay the prorated penalty cost for January through December or for April 15th through December? Okay, I think I understand what you're asking there. Your question is, an individual is uncovered for a couple of months during the year. Let's say it's the last 3 months of the year. They figure the penalty for the entire year, January to December, Then they divide that by 12, and they pay that number, that divided by 12 number, times the number of months they were uncovered. So if they're uncovered in September, October, November, and December, that individual pays 4 times 1/12 of the annual penalty. So there is no April 15th to December penalty. There's one annual penalty divided by 12 times the number of uncovered months. All right, just to clarify, the navigators can print the 1095-A for a consumer if they are in the office for an appointment, but not if they call by phone and request a copy. In that instance, we would direct them to the New York State of Health phone line. You perfectly explained the rules around printing a 1095-A. If the consumer comes to you, says, I don't have a computer or access, but I remember my username and password, I'd like to log on and print it in your office, they can do that. They may not call you and say the exact same situation, I don't have a computer and printer and blah, blah, blah. Could you print it out and mail it to me? You may not do that because it's sensitive tax information. We can't just be distributing it without there being a proper control. When they call the New York State of Health, a notation will be made that a change of address was put in there, or it's essentially complying with a lot of federal laws around distribution of tax information. So if the consumer accesses it on their own, on your computer and prints it out, no problem. You may not mail it to them. So I really appreciate that explanation and that clarification. It was perfectly well said. All right, we were told that unless an applicant selected yes on the Build Household page, checking for getting assistance, they would not be eligible for financial assistance in 2014 at all. Now you're saying the PTC can be filed by any taxpayer regardless of whether or not they answered the questions, which is really correct. The information I gave you is really correct. Regardless of whether or not a taxpayer selected, I would like to be screened for financial assistance. They may file for premium tax credits if they're eligible for premium tax credits. Because they decided not to be screened for financial assistance, they may have been Medicaid eligible, and their income have been below 138%. That individual will not be eligible for premium tax credits because they were Medicaid eligible. Now, if an individual was screened for financial assistance, was found eligible for APTCs, and their income at the end of the year was Medicaid eligible, because they went through the screening process, they can still file for premium tax credits as if their income was 100% FPL, because the screening process is the exception to the rule. If they chose not to be screened and they were Medicaid eligible, they may not file for premium tax credits at the end of the year. But if they were screened and were found APTC eligible, then they can be. If that's complicated and you didn't catch it all, that's why we have our helpline. Direct them to us. We'll explain exactly what the exceptions are and how it applies. Will clients who receive Medicaid through the marketplace receive a tax form as well? No. The only taxpayers who will be receiving the 1095-A are people who enrolled in private insurance through the marketplace and selected a bronze, silver, gold, or platinum plan. They selected a catastrophic plan or they got Medicaid, they will not be receiving a 1095-A. The 1095-A's only role is to help the reconciliation process. Would it be possible for the New York State of Health's Eligibility Department to offer training on proof of income documentation, particularly for non-traditional applicants, e.g. seasonal workers, individuals who are out of work on disability, blah, blah, blah? In my experience, New York State of Health... Oh, I'm sorry. Somehow the 1018 number went below. That's been answered. So that's all the tax questions. I'm done. It's 12:45. I'm handing it back to Carolina. I hope that was clear to everybody. If not, you have my contact information.
And so if you thought this training was rushed, it was very rushed because you guys are getting a full presentation tomorrow from the state. Watch it. If you cannot obviously see it tomorrow live, it's going to be recorded. After you watch that state presentation, and maybe after you start seeing clients, I can beg Kyle, who's going to be really busy running the hotline program that we're going to have here at CSS, to come back and maybe if you guys send me questions in advance, we can do a quick PowerPoint, nothing too in-depth at that point. But you're all free to go. Expect a big weekly email, obviously, for this week, because I'm not going over the marketplace updates or other information. I'm just going to send it to you via email. If you have any specific questions that we didn't get to, as always, Leon and I are here to help.
All right, just some final announcements. Everybody, please enter all your data into the CNN enrollment database. As I mentioned earlier, November and December monthly enrollments, monthly reports are due. It's now part of the CNN enrollment database. Every organization did identify somebody at their organization that is going to be doing that monthly report. Please submit it for December. If you did not do November, it's overdue. Please submit your November report today. Those people know who they are. I sent you a personal email today. Please get the information in. And one final thing, the sites, the enrollment sites for February 2015, they are due. So if you just have it, if there's no changes from what you submitted for January, just shoot me an email. Hey, Leon, there's no changes. If you do have additional sites, if you're removing sites, let me know. I'm going to send out the Excel file before today is out. Once again, Happy New Year to everyone. Thank you for the great work that you're doing in the community that I shared. Any questions up from Carolina directly, we'll answer those questions. We're way over time. Thank you for spending this time with us today. Enjoy the rest of your day. And, thank you. We'll post all the information. Carolina will send out all the slides that were shared today via email by the end of the week. Take care. Enjoy the rest of your day.